international webinar today, and it is titled Experience Innovation Freeform Diffractive Technology Unveiled. And we have a renowned speaker with us today, Dr. Ryan G. Smith, who's cataract and refractive surgeon from Pacific Eye Institute, uh, Upland, California, and associate clinical professor of ophthalmology, UC Irvine Department of Ophthalmology. We have with us the chairperson of the meeting as well as the moderator, Dr. D. Ramamurthy, chairman of the Eye Foundation Group of Hospitals, Coimbatore, and also the past president of the All India Ophthalmological Society. Apart from this, we have a galaxy of expert panelists. Dr. N.V. Arulmoi Burman, Medical Director, Uma Eye Clinic, Chennai. Dr. Purendra Bhasin, Chairman and Managing Director, Ratan Jyoti Group of Hospitals, Gwalior. And Dr. K.V. Satyamurthy, Director, M.M. Joshi Eye Institute, Dharwad. So, welcome everyone. And I would now request Dr. D. Ramamurthy, who's the chair for this session, to please take over. Over to you, Dr. Ramamurthy.
Thank you, Namrata. Let me just share my slides. I think a very warm welcome to one and all of you to what we expect to be a very vibrant discussion and on the experience innovation, freeform diffractive intraocular lens technology, which had been unveiled to the Indian markets just a couple of months back. We were all gathering initial information. But to get to know more about this lens, we have, as Dr. Namrata already mentioned, Dr. Ryan G. Smith, who is a distinguished anterior segment surgeon with recognized experience in refractive cataract surgery, corneal surgery, complex anterior segment reconstruction, and advanced intraocular lens technologies. He has had a wonderful career. He did his fellowship in cornea and refractive surgery at the University of California, Irvine, and residency ophthalmology residency at Stanford University. He served as a co-chief resident, which I think is a great distinction. He has been awarded the ACRS Resident Excellence Award, uh, being recognized as one of the top US residents. He has also been awarded the Stanford Marmor Blumenkranz Research Award and the Stanford Lodge Seat Funding Award. He's in the national committees as a Young Eye Surgeon Clinical Committee, Digital Clinical Committee, Sustainable Clinical Committee. He has been honored with the RWO Practice Trailblazer Award and the ACOS Aspens Mentorship Honorary Recognition. Obviously, a very distinguished person, and we look forward to hearing his thoughts on that. And as Namrata already mentioned, we have a galaxy of Indian stars here. Leading the team is none other than Professor Dr. Namrata Sharma, who only yesterday was conferred with the Dr. Duke-Elder International Award. Truly a matter of great pride to all of us. Hearty congratulations, Dr. Namrata. And as a professor of ophthalmology from RP Center, as well as leading light in the All India Ophthalmic Society, presently the chairperson scientific committee. She has brought in wonderful changes. I know Dr. Arulmozhi Varman, our careers almost paralleled each other's, and uh, we've been known to each other for almost 4 decades. And he's always at the cutting edge of cataract and refractive surgery. It will be great to hear his thoughts. And Purendra Bhasin, as the chairman and managing director of Ratan Jyoti Group of Hospitals, very deeply involved in the administrative aspects of hospitals, but at the same time, a great thought leader as far as cataract and refractive surgery is concerned. Then we have Dr. K.V. Satyamurthy doing excellent work in Dharwad and Hubli as a director of the M.M. Joshi Eye Institute. Again, very much in the forefront of cataract and refractive surgery. So we are looking forward to an afternoon of great learning. And let me hand you over to Dr. Ryan to take us through his presentation. Welcome, Dr. Ryan. You can go ahead and share your presentation.
Wonderful. Is presentation showing?
Yes.
Screen sharing? Okay. Great. Well, thank you all again for joining me. It's an honor to be here. I'm excited to talk about freeform diffractive optics and my experience with the Odyssey lens. So as we know, patient satisfaction is the most important for what we do, and our patients demand the best vision. And so I want to share with you all my experience here with the Odyssey lens. I have done over 250 implants. I was first in the country and in the world actually to have access to it in the limited market release in the USA. And I really just can't speak enough about the distance benefits of this vision. Of this lens. It just gives fantastic distance vision. It has a better dysphotopsia profile, I find, than the competitors with great contrast sensitivity and ultimately less chair time, which has really been a huge boost in my clinic. So, what is the Odyssey lens? Well, we'll talk about the freeform diffractive profile of the optics, which make it so unique, but it delivers this enhanced tolerance to refractive error, and I think that's really key in getting the great outcomes. It has an optimized dysphotopsia profile with a great range of vision and best-in-class contrast. And, Johnson & Johnson celebrating 25 years of the Technis platform this year, and that is the foundation for why this lens is so fantastic. It has the least amount of chromatic aberration of any lens. And because of that really high Abbe number, it has the most amount of light getting into the eye. And so they're able to do more with those optics and deliver sharper vision as well with correcting the spherical aberrations from the cornea. And the Technis design, we know, has low rates of PCO and capsular phimosis, which are also so important for our advanced technology lenses, and they're glistening free. Here's what I'm talking about when I talk about that high Abbe number and just how good the contrast is. You can see, yes, there's no free lunch in optics. Compared to the Technis One Piece, there is a slight decrease in the contrast sensitivity, but it's actually 15% higher than the Alcon monofocal. And 2.4 times higher than the PanOptix lens. So the Technis material is able to give those high quality vision optics and really decrease aberrations. So what is the freeform, diffractive profile? It's a really cool physics term. It sounds like marketing jargon, but it's not. The basically traditional lens design is you design the lens, then you see what vision it gives and go back to the drawing board. But what the engineers were able to come up with is actually using this freeform design where you say, you design what vision you want, and then using computer learning and advanced formulas, design a lens around that. So you can see here the overlay in the light gray of the Technis Synergy versus the Odyssey. And there's custom echelettes. They're much softer in many places, but still sharp in others. And overall, there's 50% smaller step height. So this allows for more precise light control, and it really helps to minimize dysphotopsias. And because of all this, it has a great tolerance to refractive error. So over 95% of eyes achieve 20/25 or better distance vision, even under defocus of up to half diopter of myopia or hyperopia and 3/4 of a diopter of astigmatism. It also has a reduced halo profile. So compared to the PanOptix, you'll see much less halos and much, much less starbursting with patients. And that's borne out in my experience as well. 93% of patients reported, either didn't report any visual disturbances or had mild halo and glare at the 1 month post-op. And again, patients just really like this lens, and there's so much less chair time as we talk about this. The optics of the lens are also great because it has this wide sweet spot. So the landing zone here is much more forgiving. And then the area under the curve is 17% more than the PanOptix lens. So it's giving you that better distance vision as well. Here at the more near, you're picking up more. So patients can read 14% smaller print size. 93% of patients in the clinical trial are spectacle independent. That's what I tell my patients. The goal is 90% of the time we're going to get you out of glasses. And at 3 months, patients had 20/20 uncorrected distance vision, which is so key, and then fantastic intermediate and near vision. Overall, this lens just really delivers precise vision, at every distance, and most importantly, with any lighting. 92% of patients were satisfied with their ability to see steps and curves at night. Let's not forget this is you know, cataract surgery and including refractive cataract surgery are still safety first procedures. We need our vision to navigate the world safely. And so we have to be able to see in all light conditions. And I appreciate that the Technis platform is able to deliver that here with the Odyssey lens. So let's get into my clinical experience. When you're selecting patients for this lens, it's really important, and I advise with any new technology, you want to start with the home runs. You want a healthy cornea. I can't emphasize enough that ocular surface is paramount. I wouldn't recommend starting in patients who've had prior corneal refractive surgery or other intraocular surgeries. Avoid irregular astigmatism and scarring and high angle kappa and angle alphas. Also, we can get into this, but at the beginning, at least, no glaucoma or retinal pathology patients. And then it's, with any lens, important to assess the patient personality as well as visual needs. I am a big fan of underselling and over-delivering. So I tell every patient, I show them a gummy of the lens with the rings. And I said, the lens has rings. That's how it works. You will see them at night. That means it's working. And if that's going to bother you, we can talk about other options. But if you want the best range of vision, the best vision at the best range, this is the option for you. And as you get more comfortable with the lens, you can use it in post-refractive situations. So I have a lot of patients who are post-LASIK and post-PRK on prior myopic treatments when they have a clean scan and their corneas look good. I have used this with great success. You really want to check the higher order aberrations, make sure you're using maybe minimal to moderate at most, and then avoid diffractive optics in post-RK patients. I wouldn't advise that. Again, I tell my patients the goal is 90% of the time to be spectacle free. I cannot make you 20 years old again. And our patients just have these unrealistic expectations that they're going to be 20 and they're going to be able to see everything. And I tell them, if that existed and I invented it, I'd be on an island somewhere. I wouldn't be here doing your surgery. And so, this is the best technology we have, but you have to have realistic expectations. You will always find something you want glasses for. My goal is that you spend 90% of your day without them. And that's been very helpful for my patients because that's rung true. And I tell them again, you're going to see some glaring halos around lights at night, and they improve over time. I think the big difference with this lens, and I tell patients, and patients have told me this really, is that you will see halos around lights and around headlights approaching you, but they don't cross into your lane and they don't impact your driving as much as some of the other diffractive lenses on the market do. And that's been key, I think, in why this lens has been so successful in my practice. Patients still have neuroadaptation. I do think this is a quicker lens to neuroadapt in my experience than other lenses out there. Binocular summation is real. It does improve the vision even further. And then let's talk about dry eye because that's real. If you don't diagnose a patient with dry eye before their surgery and then after they're having refractive instability, you caused it. You caused their dry eye. And so I pretty much, I practice in a very dry environment. Pretty much all of my patients have MGD and some level of dry eye. And so I really talk about that with them before surgery. And I'm really known actually for not signing patients up for surgery when I first meet them because their eyes are too dry. And I'll even hold up a gummy lens and show them, your astigmatism measurement on the IOL master says to put the lens, at 90, your Pentacam showing me 150. If you really want surgery next week, I'm going to make you pick where we put the lens. And most of the time at that point, patients get the message and they say, okay, I'll treat my dry eye. We'll come back. The goal with any dry eye treatment is you want to make sure you get them to a level they can continue. We, of course, can make any cornea look perfect for surgery, but that's not doing ourselves or our patients any help. And so I always tell the patients, I can't be there with you every day and remind you to do your homework. So let's see how you do. And then when you come back, we can reassess. And ultimately, you can't drive a Ferrari fast with a dirty windshield, right? And that resonates with patients. So when you're targeting, you really want to aim for plano to first minus. So targeting slight myopia, it's not necessary as in, the Synergy lens, we did a little more targeting of plus. With this lens, you want to go first minus. You'd still want to minimize your residual astigmatism, even though the lens does have that tolerance to refractive error. So I always try to get it down to less than a half diopter, either with a toric or using femtosecond, if that's available. And for your lens constant across the Technis platform, they're all the same. So you can use your personalized constant, for your ZCBoo, for example, or 119.3 if you don't have a personalized constant. And I use the Barrett Universal 2 personally, but choose your modern formula that you feel comfortable with. Again, post-operatively, continue optimizing the ocular surface. Be really careful with autorefractors, right? With diffractive optics, it can over-minus your patients. You really want to push plus in those refractions to get that optimal visual acuity and measurement. And then again, managing post-op expectations. Many patients I find when they have to pay for these lenses, they expect the world and they can sometimes forget that conversation that you had with them in pre-op. And so we have them sign consent forms and acknowledgments. And I just remind them in the post-op, you see the halos. Yes, that's how the lens works if they bring it up. It's going to take time. Are you not, most of the time not needing glasses? That's the goal. And again, best vision's achieved with bilateral implantation. Overall, I've got really consistent outcomes and it's really simplified my practice. The patient satisfaction has been excellent. I was a little hesitant coming into this with Synergy as the lens I had used before. I had really good success mixing and matching that with with Symphony. But certainly I think some of us, Synergy provides fantastic near, but you have a higher dysphotopsia profile. This is not Synergy. It's very different in how it works in these patients' eyes. And the explant rate speaks to that. I have only personally explanted one pair of lenses in all the patients that I've done. So, patients are very happy with this lens and the optics it provides. And I do find it neuroadapts faster, in my personal experience. Honestly, I actually forgot what it was like to counsel a multifocal patient in that chair time in the post-operative period until I started doing my PanOptix Pro and my Envy trials. And then all of a sudden I had patients in week after week, that same patient back every week. I still have all this glare and halo at night. I can't see like you told me I'd see. And having to really coax them through and coach them and hold their hand through that process. Can it happen with Odyssey? Sure, but it's definitely dramatically reduced to the point that I don't even remember the last time I had that conversation with an Odyssey patient. And I think a lot of that, like I said, I underpromise and overdeliver. That expectation setting is key. And patients have been really happy. So there's some literature out there on comparison to alternative, ATIOLs. So there was a study from Journal of Refractive Surgery just this April that compared Odyssey to Synergy to PanOptix. And it found that the far and intermediate trended better in the Odyssey group, and the contrast sensitivity and glare size were significantly better in the Odyssey group than the other groups, suggesting it provides better uncorrected far and intermediate visual acuities and has far dominant properties and greater tolerance to refractive errors. And that's really important to me because while we want to provide the best range of vision for all of our patients, you don't want to give up the distance vision. And that was just something that I found, especially when I was doing PanOptix before I switched to Synergy and then Odyssey, was that, my patients would test at 20/30, 20/40. And when I ask how their vision is, they say, it's fine, it's okay. Yeah, I don't need glasses, it's okay. But there wasn't that excitement that, wow, I can see everything. I have eagle eye vision. And that's what generates more referrals. That's what, the word of mouth, friends and family come in. Gosh, my, cousin had this lens and they won't stop telling me how amazing their vision is. And that's what I want for my patients. I want that amazing distance visions. Yes, we have more time on our phones and technology, but we drive to work. We have to get there safely. And the Odyssey lens just really delivers that. There was another study out of Baskin Palmer comparing Odyssey to PanOptix. Small study, 38 eyes of 19 patients, and they found a significant better contrast sensitivity in the Odyssey compared to the PanOptix, and better distance vision again. So at this point, we'll switch gears here and we'll run through some cases. So the first case is a 63-year-old female. She's got well-controlled diabetes, comes in for her cataract evaluation. She's got glare and trouble reading. This is a very standard patient. She does have some anisometropia due to that myopic shift in her right eye, and she's right eye dominant. She has some dryness, not too bad. We can take care of that with my basic, warm compresses and tears. And she's got significant cataracts. Here are measurements on the IOL master. You can see she has significant with the rule astigmatism. And then I always check for foveal centration as well with these and look at my bonus topography scan that the IOL master provides. And then I also look at a pentacam for all of my patients. I do like the holiday report. I look at both the eCase R65 here, and then this is my way of checking higher order aberrations. So her corneas look nice and clean here. She is consistent with the rule astigmatism, and she wants spectacle independence, but she's really concerned with the cost of advanced technology IOL. So she decides to go for a toric lens in her dominant eye first, and then we'll come back and stage the left eye when she's ready. And she's thrilled with her outcome. She's 20/20 uncorrected, but then she comes back 5 months later. The glare is worsening in her left eye, and she's got blurred vision for near with both eyes. And so she really wants more reading vision now. And so I talked with her about using the Technis Odyssey toric lens, and that there would be a risk of glare and halos compared to her right eye. And she decided to go for it. So we did an Odyssey toric. I use Aura, so I always pull a range of lenses here. And I also use the Callisto system, which I find quite handy for marking the patient and for making sure as well that I'm doing a capsulorhexis in my patients who don't elect femtosecond laser. I still try to make, between a 5 and a 5.5 millimeter capsulorhexis. I use a stop and chop technique. And then again, the Callisto markerless system is great for aligning the lens here and making sure I get it right where I want it. I really like the haptics on the Technis toric platform. They frosted the haptics, and so they just don't move. Even when you go in for IA, it doesn't move, and it's very stable. I haven't had to take one back to rotate. And so that's been very helpful as well with these patients. Of course, you want it well centered. It does have a larger button, which I appreciate, but I try to use the Purkinje image there as well to center it. So at week 1, she's 20/40 uncorrected. Near wasn't checked. I go to 5 different offices, so I don't always and get all the measurements on every patient. But at her month 1 visit, I saw her back. She's 20/25 uncorrected J1 with minimal residual refractive error. She's thrilled with her vision outcome. She's comfortable reading for short to moderate periods of time. She does not bring up halos, but of course I asked. This was one of my first patients and the first monocular patient I did. She says she notices them slightly at night, but headlights don't bother her. And so, we've learned with some lenses, for example, Vivity, it was not good in a monocular situation. But the Odyssey, after this patient, I've used in many situations where we could only upgrade one eye. Maybe they already were pseudophakic, maybe they had, pathology in the other eye, and patients have done really, really well with that. Let's talk about a bilateral case now. This is a 68-year-old female who presents for cataract evaluation. She's bothered by glare and halos at night. She has blurry vision in the distance. She's got itchy eyes, which I have a lot of patients with. She's hyperopic, right eye dominant, 20/20, but bats down. And she's got significant scurf and Demodex and dryness on her cornea. So this is one where I said, nope, we're not doing surgery, unless you're going to go with the insurance covered lens. And instead, we're going to address the ocular surface using prescription medication, lid scrubs, compresses, and tears, and then we're going to recheck everything. And this is important, what I was talking about of I want to get my patient's ocular surface to homeostasis, what I call reasonable and achievable homeostasis. So when my patients come back and their eyes look better and their surface looks better, I ask them, is this something that you can keep doing long term? They think that we can cure their dry eye, even though I start off by saying it's a chronic condition. And so if the patients, and sometimes they say, Doc, this has been so onerous, there's no way I'm going to do this after surgery. I just want to let you know that, but I still want everything. That's one conversation. And I say, I don't think this is a good match for you technology wise. But when the patients say, yep, nope, I can build this into my routine. I understand I'm gonna have to keep doing this long term. Great. That's the reasonable homeostasis I want to achieve for them. So here's her IOL calculations. Pretty standard measurements, minimal astigmatism. Pentacams look clean as well, the right and left eye. So she's back, her cornea is clear, the surface is optimized, and so we planned for Odyssey for full range of vision in both eyes. In the right eye, I targeted a plus 0.10. She was 20/20 -1 at day one. Week one, she was 20/25 J1, and she ended up slightly myopic. You'll see some of my targets end up like this. One of my IOL masters, depending on which office the patient goes to, tends to do that. So I have to budget for that based on where the scan came from. And then in their right eye, she was 20/40 day one, week one, 20/40 J2. And then at month one, she's 20/20 J1. So certainly, right, great vision off the get-go, but it gets even better. There's still neuroadaptation, and you got to counsel patients about that, but they do really well. And I would say this is a very kind of standard experience for me across the board. She's got improved vision in all ranges. The patient's happy. Again, ocular surface management is paramount to success with advanced technology lenses. I can't emphasize that enough. And counseling and neuroadaptation are important as well. So what about some comparator cases? So I mix and match. I do that a lot with a lot of different technologies, depending on what the patients are coming to me with, what their goals are. So this is a case of a PanOptix versus an Odyssey. I have a 73-year-old. She comes in for cataract evaluation. She's bothered by blurry vision in her right eye, glare and halos at night, blurry vision at distance, and she has tearing. Well, she's got MGD, as I said, most people in my practice do. The right eye had PanOptix placed a year ago. The posterior capsule is intact and clear, and she just has not neuroadapted. Her left eye, she's got 2+ NS and a trace PSE cataract. She's left eye dominant. Her exam's otherwise normal. There's no changes on DFE or OCT. And you can see in her right eye, she's 20/40 uncorrected, J3. She has minimal residual error and corrects to 20/25. And I think that's a pretty classic experience for me with the PanOptix lens. And her left eye, corrects to 20/20, but she's having issues with glare. So before I get to the measurements, actually, one thing about this patient, we waited years. She came back. I offered to take the lens out of her right eye, but she still didn't want to give up her near vision, but she hated that lens and definitely didn't want it the other eye. And we went back and forth, back and forth, back and forth. And then she came in and she said, I can't deal with it anymore. So I condensed that, but these are the measurements from at the bottom here, her pre-op visit. And you can see here, her right eye does have more astigmatism than the left, but the left has astigmatism to some degree as well. She's got some ocular surface issues. She's got moderate HOAs. It's not the most perfect of corneas for this, for any advanced technology lens. And she's got that moderate against the rule astigmatism. So this is one of those tricky patients who I saw many times over many years and counseled extensively. She was so unhappy with her PanOptix eye. I said, I'm never putting a diffractive lens in you, back when I met her years ago. And on top of that, she has moderate higher order aberrations, but she just tells me, I will not wear spectacles. I have to have the best distance vision and I need to be able to read. So I actually really pushed the light adjustable lens on her so that she'd be in control of her outcome. I did talk to her about Odyssey versus Symphony. This was one of my early Odyssey patients. And I said, let's do femtosecond, whatever you choose, so we can cut down your astigmatism. And she went with the Odyssey lens, and I was pretty apprehensive about how she was going to do, but I had read her the RIDE Act, and thank goodness she was thrilled with her outcome. She was 20/20 for distance intermediate and J2 near. Pretty similar refractive errors between the two eyes, but even so, the left eye, corrects to 20/15. And, she says, you fixed my vision. This is so much better than my right eye. She doesn't bring up halos, but of course I asked the difference. And she says she notices them slightly at night, but headlights don't bother her. And it's nothing like she sees in her right eye. And that's really important, right? Because in the US, we drive on the other side of the road. So our patient's right eye is the one that's exposed to oncoming traffic. And so generally, Excuse me, our patient's left eye is the one that's exposed to oncoming traffic. So generally it's the left eye that they're going to notice all the problems with. And the left eye here got the Odyssey and she's perfectly fine and still more bothered in her right eye, which is not getting the same amount of exposure from that oblique angle of the headlights. And even with her residual astigmatism, the Odyssey was able to outperform Panoptix for crisp distance and clear vision at all ranges. I think that again just speaks to the forgiveness of this lens. Again, it's not something we want to bank on. I did femtosecond. I did everything I could to cut down her residual refractive error, but the patient just did fantastic. And then more recently, I had a patient, who had a Panoptix Pro and came to me. She was 69. She's mostly bothered by vision in her right eye. She had had her left eye done elsewhere, but her insurance changed and she wanted to match her left eye. And her surgeon is a friend of mine and suggested me. So she comes in and she has a Panoptix Pro and 12.5 diopter lens that was implanted with femtosecond laser and Aura. And she's super happy. I'd like to match my left eye, she said. So yeah, her surgery was just 2 months ago. Her left eye is got a pretty significant cataract. She is right eye dominant. And so, sorry, it's her right eye that has the cataract. She's right eye dominant. Her exam's otherwise normal. There's no changes on her DFE or her OCT. And she's really batting down. She doesn't see well at all in the right eye, although she is correctable, but she's quite a myope, -6.5. So her eye in the right eye isn't quite as long as the left eye, but again, the measurements are pseudophakic in that eye. And here it's calling for more in the Odyssey of a -14.5, something along that range. She's got minimal to moderate astigmatism. She's got moderate higher order aberrations here. Her left eye looks cleaner, okay, especially from a higher order aberration standpoint. And so I talked with her, she really wants spectacle independence. Again, she's happy with that lens in her left eye and she'd like the same lens. But at this point, I had already done my trial. And I had told her as well, look, your corneas aren't the same. Your eyes aren't the same here. I'm seeing more higher order aberrations in that right eye compared to your left eye. So there's a higher risk you're going to have dysphotopsias and glare. And so I offered her the Puracy lens because she was happy with the reading in the left eye already. So I said, let's, make sure we don't induce any more issues. And you've already got the reading. Let's go for the best distance. But she doesn't want to wear glasses at all. And she's got to have best distance vision. She drives her grandkids around, picks them up from school, takes them to their activities in the evening, at night, while her children work. And then, but she also likes to read as well as a hobby. And so I said, okay, well, we can talk about Odyssey or we can do Panoptix Pro. And she said, I already like what I have. And I said, that's great. But, every lens is different in different surgeons' hands. And I found this to be true, for me. And I told her I did Panoptix and I stopped doing it because my patients just weren't getting the outcomes I wanted. I tried Panoptix Pro and I went back to Odyssey because I was spending all this time counseling my patients on dysphotopsias and things I hadn't talked about in a couple of years. So I told her, look, I'd be happy to match what you have because I know you're happy with it, but I also have to tell you about my experience. And, if you would come to me from the get-go, I would have put an Odyssey in both eyes. But at the end of the day, it's your eye. I'll do whatever you want. You can pick. And so she ended up picking the Odyssey lens. I used Aura here, and so I picked a 14 diopter lens. Again, this was the IOL master for me that ends up being a little more myopic in its outcomes. And she's thrilled with the outcome. She's 20/20 -2, 20/25 intermediate, and J1 near. She did end up a little myopic with little residual refractive error, but her spherical equivalents are minimal, and she corrects better in the right eye than the left eye. And most importantly, she's thrilled with her visual outcome. She says, wow, my distance vision is even better in this eye. Thank you so much. When I had to ask her the difference between the eyes, she says, I thought my left eye was good, but my right eye sees even sharper. And that's what I'm talking about with that clear distance vision that patients get with this lens. They feel like they have Superman vision. And when asked about dysphotopsias, she says she sees them in both eyes, but she prefers the Odyssey eye. I see the halos, but the streaks don't appear to cross the lane like they do in my left eye. And the patient notes she's spectacle independent at all ranges. So again, the Odyssey delivers superb distance vision results while providing the full range of higher quality vision, in my opinion, than the Panoptix Pro. So one last case here, you know, oh, sorry, that is an extra slide there. So what about in a patient with a difficult case? I am very conservative, I think, when it comes to putting in these lenses, but with the right counseling and appropriate backup plans, I think you can use diffractive optics in difficult cases as long as the patients are aware they, in the middle of surgery, I might decide it's not the best thing for them. So one example I wanted to share is a patient who I saw who had white cataracts and posterior synechiae. This is not someone who I'd be super excited about putting a diffractive optic in. But in this case, the patient had already undergone a monofocal in the first eye and was 20/25. And then upon regaining their vision, said, but wait a minute, I can't read. Why can't I read? I want to be able to read as well. So they inquired about their options for the second eye. It's a white lens, but the B scan is clean. Of course, that only tells us so much. And so I told them, look, I feel better about the situation knowing your other eye is healthy. So this one's most likely healthy, but I can't promise you that. We can consider an Odyssey lens if I can remove your lens safely, the support structure is intact. And I think it's safe, but just know, you might end up with a monofocal lens if there's any complication or issues that arise. So for my white cataracts, I decompress all of them with a 25 gauge needle on a 3 cc syringe. I've just made that standard practice, and it's saved me countless times. So I'll share my technique with you here. Of course, this one had the joy of the posterior synechiae as well. So I try to do as much synechialysis as I can with my viscoelastic cannula. Otherwise, I'll get out an iris sweep. Here, I then put in a ring to get my pupillary dilation. I actually then IA out my viscoelastic before I stain. I find it works much better than painting. It's one extra step, but it doesn't take that much time. And then the key when staining these is you really have to wait longer than you think. So this is sped up, but it's kind of almost a painful amount of time that you're waiting to get that good stain. But again, in a white cataract situation, you want to make sure you have good visualization. So I come in here with the needle. You always want to prime the needle first so that the plunger is not stuck. And you can really see I aspirate a good deal of material. You can see wrinkling of the capsule. So we're removing a lot of pressure here. And then I always refill with viscoelastic to make sure I've got good tamponade there. And then I can go around and do a normal rexus. And so this patient, I was able to get the lens out safely, ensuring it can rotate. And we had zonular stability. I'll either do a vertical chop or a stop and chop generally for these cases here, as you can see, for nuclear disassembly. And again, I think you can, even as a conservative surgeon, implant multifocal and full range optic lenses in these difficult cases with the right counseling for the patient and setting the right expectations. Thank you all so much for your time. Again, it's an honor to be here. I look forward to our panel discussion and any questions you may have, and feel free to reach out to me as well if there are further questions.
Thank you so much, Dr. Ryan, for that excellent presentation. Maybe you can stop sharing your slides.
Yep.
So I think apart from the details about the lens, what we found very interesting was the knowledge sharing about your clinical experience with these lenses. Just to set the ball rolling.
Let's see, did the screen share stop? Sorry.
Yeah, there it is. Um, the Odyssey lenses have come to India only recently, and we're just gathering our initial experience.
Yeah.
But the POC has been around for some time, and many of us have used that with a little bit of micromonovision. It has worked very well in our hands. So especially in a case like one of them you alluded to, where the patient is not quite unhappy with the panoptics in one eye, we would maybe tilt towards putting in a refractive technology lens like a POC, giving them some amount of near vision, good intermediate vision, and hope that the patient will end up being happy. So this is a fairly in the sense that one multifocal, trifocal, the patient is not happy, and you're going in. That's the kind of confidence that Odyssey has given you.
Absolutely. I mean, this, at the time of that case, I didn't have PRC yet. We just got access in March. And so but I knew it was coming. I've known about it since, they were developing Odyssey. And I had actually told them, forget about Odyssey, just give me Puracy. And they chose to go, oh, the rest of the world got Puracy, we got Odyssey, and then now we're all getting everything. And I'm so thankful I got Odyssey because it really has been fantastic. And I mean, this was a patient, literally, I think it was like 3 or 4 years. What do you have, doc? Do you have, can we do this? I can't stand this. I tried to take the lens out. She wouldn't let me. I said, let's wait and do a Puracy. It'll be here soon. And she said, no, even if it's here, I want to see distance. I want to see close up. I don't want glare and halos. And so that's why, I really pushed light adjustable lens because that's the closest thing to Puracy we had. We could kind of create a Puracy with it in the adjustments, and she wouldn't go for it. But yes, with with how good it's been in my patients, I still counseled her extensively, knowing how much I had to deal with a prior surgeon's chair time with the other lens. And she's been so happy. And her biggest regret was she didn't do it sooner.
Mhm. My co-panelists, please get going.
Yeah, I've used a small number of ODC lenses, about 50 odd, and the results are quite good, as Dr. Ryan has mentioned. The distant vision is absolutely great. I really don't have enough data to talk about the contrast sensitivity, how much it is better than other lenses. Again, it's only the patient's subjective awareness about glare and halos appears to be lesser than the other lenses, like definitely lesser than Panoptics, probably a little lesser than Synergy, and near vision is excellent too. So overall, what I have got is patients who have got very good satisfaction overall with all distances. And all my patients are either one eye with Odyssey or both eyes with Odyssey. I have not tried a mix and match yet. So after listening to Dr. Ryan, probably I will try out a few of these mix and matches.
So do you mean to say, Arul and Ryan, in the sense that in case you have a patient who already has say, a Panoptics or a Synergy, when they come for a second eye, just because we have a better lens now, you will offer an Odyssey, even if the patient is reasonably happy with the first eye?
No, I would probably do that.
Dr. Ryan?
Yeah, that's what I've done with many patients. Where I stood coming into this, the launch of Odyssey, was I had shifted from, I had done Panoptics, then I did bilateral Synergy, but certainly, I think Synergy had a mixed surgeon experience. You really had to optimize the ocular surface and nail the target. And I was actually doing second plus when I was doing Synergy. And I had some bilateral patients very happy. And then I had some, who were bothered by the dysphotopsia. So what I ended up doing and settling on for over a year was I would start with Symphony in their dominant eye. And then I would, if they wanted more near, I'd give them Synergy, or I would just plan for a mix and match. So I was hesitant when Odyssey came out because of my Synergy experience with, because the Synergy gave that great reading, really, really close up reading. But you just had to counsel patients on everything else that comes with it. So with Odyssey, I started the same way. I would do Symphony and then do Odyssey. But interestingly, patients preferred their Odyssey lens over the Symphony lens. So after kind of a month or two of that, I said, okay. And many of my colleagues have shared the same, that they then went to bilateral Odyssey, and then just putting it in anyone, who would come in with an older lens but was ready for their second eye.
Great.
Yeah.
Yeah, go ahead.
Yeah, Dr. Ryan, want to ask this, the quality of this Odyssey lens, you are saying it appears to be, in your the opinion, it is better than Panoptics and the other available lenses, trifocal lenses in the market. So, just want to know that how do you, what is the best thing in Odyssey, which you will say, whether the Technis platform per se, or the change in the rings which they have made, the shortened height of the rings, which is giving this better quality, less dysphotopsia and better quality vision?
I think it's the combo. right? Because, we've had Technis lenses with multifocal, and everything. So the Technis platform has enabled that, but it's really twofold. You have Technis with the really high ABI number, so you have so much light coming into the eye, so you have more light to play with. And then it's not just that they shorten the step height, it's that it's customized. Each dot on the lens, as they built it out, is customized for the vision they wanted to achieve. And so some of the steps are steep, some are just more shallow, some have a sharper edge, some have a more rounder edge. So I think it's that combination. I'm not sure you could put that on, a Clarion or some other platform and get the same. I don't think you would get the same result. So it's that combination of it, but certainly they've taken everything they've learned and then gone to the next level.
I think one of
You have
the
shown,
best.
yeah, please.
Yeah, go ahead, Paridna.
So we've shown multiple cases, variety of cases in post-refractive surgery, one-eye dissatisfied patient, mature, hypermature cataract, complicated cataract. So, what is your opinion that the IL power calculation or biometry matters more, or the lens matters more?
Well, gosh, I mean, it's
Because
garbage.
that is very important in all these conditions.
Right, garbage
I
in,
have
garbage
a
out.
right on dot biometry and IL power calculation.
Absolutely.
And yeah, so that is because patient experience can vary with the inappropriate biometry.
100%. And so that's why I showed, if you have the IOL Master 700 or another biometer that has the swept source OCT, you get the foveal, the bonus scan there, so you can identify macular pathology, but more importantly, you can make sure that the patient's fixated and you're actually getting an accurate axial length through the fovea. So that's why I always look at that page of my measurements. And if it's off, and clearly you don't see the dip, I have them repeat it. Now, with a white cataract, you're not going to get that. And so I, will rely on our manual readings. I do counsel the patients. We include a laser touch-up in our package. So if they are off, then, we can either correct it with LASIK or I'll do an IOL exchange. And I tell them, like, for everything we have, no one is perfect and the formulas aren't perfect. So even in a normal eye, there's a bell curve. And I explain the concept of a bell curve to patients. But 100%, if the measurements don't make sense, I remeasure. In that patient, they'd already had surgery in their other eye. And so the A scan did line up pretty closely with the axial length measurement of when we were able to repeat it with the IOL Master through their pseudophakic eye. So I take all the data into account, but 100%, if you don't have good measurements, you're not going to get a good outcome. It doesn't matter what lens you have.
Oh, just to add on to what was already said.
One question to that.
Yeah.
See, Johnson & Johnson is the only company which speaks about correcting chromatic aberration and with the highest Abbe number in the industry. How does it really add to the quality of vision that we speak of? These are I just want to know, why in your experience, what exactly?
Yeah, I mean, look, I think any aberrations in a diffractive optic, it's all going to stack on top of each other. And so by being able to correct, for those corneal aberrations, then even though you're inducing some with the diffractive optic, patients aren't going to be as bothered by the dysphotopsias and the glare. That's why, I still measure the high order aberrations to see how much extra, but I don't have to worry already about the aberrations in the cornea that the Technis is correcting for.
I'm talking about chromatic aberrations. So other higher order aberrations and the spherical aberrations, yes.
Right.
I do agree, but chromatic does it really?
Yeah, I think I'm saying both. I think it's all important. But I've tried envy. I've tried. I make a point. I'm not a believer that any company can have all the best technology, nor should they, for every patient. And so, so I try everything with my patients. I'm open with my patients, that, hey, I have this technology that I've been using. I'm excited about this new technology. Here's what the data shows. I'd like to offer that to you. You will be one of my first patients. Some patients love that. I had one who was like, if I'm not your first patient, I don't want it. And then others really, well, I want to go with the tried and true. And so I'm not shy about trying and incorporating new technology, but this has stuck despite new lenses coming out after it. And I think a lot of it has to do, can I account for what is from correcting the spherical aberrations to what's correcting the optics of the lens to the echolette design. It's all one lump package.
I think Johnson & Johnson is the only company talking about chromatic aberration because they're the only ones dealing with it, in the sense that their lens material is Abbey number is 55 compared to Alcon where it's 37. So obviously the HLA design also adds to it. And when you take care of the spherical aberration with a minus 0.27 Q value, both of them are actually additive. The Q correcting the spherical aberration and chromatic aberration together leads on to a better quality of vision. I think one of the best things they got it right is the basic platform, that is the Technis platform with the material square edge design and now the roughened haptics. So that whatever platform they come up with, they seem to be making a success of it. And as far as the formula itself is concerned, one thing I do slightly different is most of us go to the Barrett for Universal 2. We make the Barrett toric calculator our basic formula, so that if the formula suggests a cylindrical power, especially when we talk about presbyopia correcting intraocular lenses, even if it's a very basic minus 0.7 diopters against the astigmatism, we go ahead and put a toric trifocal or a toric ODC lens inside. And one other question I had for you, Dr. Ryan, is that we all know that when we're using the synergy to the first plus, and now we are going to the first minus.
Yes.
We have to talk about vision at 33 centimeters with synergy, while with ODC it's at 40 centimeters. Is it that the propensity for near vision is slightly less with the ODC compared to the synergy?
I do think it's slightly less. Yeah. I think patients, and that's where I tell them the goal is 90% of the time, out of glasses. And I also assess, right, who is this sitting in front of me? Smaller, like little old ladies with short arms, their natural reading distance is going to be closer in. So they're more likely, to perhaps prefer a synergy lens or need to wear reading glasses. So I look at their arm length as well. I ask them, where do you like to hold things naturally? And I say, well, with this lens, and I take their arm and I show them where they can expect to see. And that I think is helpful from a counseling perspective. I thought I would be doing more synergies, in the contralateral eye with Odyssey for patients who wanted a little more reading. I haven't had to. I haven't done a single one. And so it still performs quite well. And I would want for myself an Odyssey over a synergy with what I'm seeing in terms of the dysphotopsia profile, and patient satisfaction. So I think it's worth giving up a little bit. I mean, synergy has great distance too. So you're not giving up the distance. I think what they did is you get a little less near than synergy. You still get, more than panoptics, but you're not getting as much of the dysphotopsia, and you're getting that tolerance to some residual refractive error, whereas synergy, if you're off, you're off, and patients don't do well.
I have two questions from you. One is that whether you have shown that your patients are J1 for near, so whether it was at 33 centimeter or 40 centimeter one, and the second is, so I have done few number of cases when these lenses are available in India just for last few months only. So, and my patients are very happy in those I have done bilateral also, and they are good and they are very happy for distance, intermediate, near vision. But I feel that we should have a comparison vis-a-vis with one eye when there is not much of a difference in astigmatism. Both eye power is nearly same. and not much difference in astigmatism, then one eye panoptics or other lens and other eye ODC lens, then only we will be in a better position to assess the quality of vision as you have done in a couple of cases with you.
Right. Yeah. So, I mean, the only study out there was the one from Bascom Palmer where they
Basket
actually
Palmer,
did
yeah.
that. The other one was they just pulled data retrospectively. The Bascom Palmer study was small, but they did that,
38.
to compare it. So I agree, the issue is getting companies to sponsor a trial versus their competitor who's going to foot the bill for that trial if it's an IIT situation. So I've pitched it. I haven't had any, success in getting it funded. I don't have the means in our institution to do it myself, but I think absolutely, it's an area that we need, and as much as we can control for it, it would be very helpful. Yeah, absolutely. And what was the other
Your
question?
near
Sorry.
vision was at 40
Oh, the
centimeter
near
or
vision.
33?
Yeah. So our techs are trained to do 33. Can I guarantee that everyone's checked at 33? No, I go to 5 different offices and I'm not there. But they're instructed to show the patient what 33 centimeters is and to hold it there.
We instruct our optometrists to show them wherever they can read.
Yeah, exactly.
That is a good way.
Right.
Interesting.
Yeah. No, there's always some. I mean, when I do it with them, I see them. Well, they do the little move. So
What I do is I ask them to read newspaper. I give them with full illuminated in my chamber. I have kept one newspaper. So
Okay.
because that I give to the patient. Look, if you are able to read, patient is very happy to see
Right.
that. That is what I do. And really, it is interesting because the technology is interesting and the platform is old and very, very reliable and dependable, which we have been using the Technis platform. And we are excited of using this Odyssey in our country. And your experience, definitely, it is going to strengthen our confidence in using them more for our patients.
One last question. Do you do simultaneous cataract surgery or you do sequential? And if you do sequential, do you play around with the power in the second eye, depending on the outcome in the first eye?
Yeah, great question. So I do sequential, and I do that. I try to start with their non-dominant eye, unless the cataract's much worse in their dominant eye, then I do the worst eye first. I generally separate them by 2 weeks. I'd like to do one, but logistically, it just hasn't worked in my practice to be able to get them in for their manifest at 1 week reliably in between. And so I will fine tune, and I have found that, has helped me and saved me when sometimes I'm a little off target. That's how I figured out my IOL master was, more myopic in one office, but we have 3. So I have to see which one, they get it from and then make my own internal nomogram corrections for that. And I found that to be helpful. Like, there's plenty of data that shows there's no evidence for that. There's also data that shows it's helpful. So I think it's surgeon experience, but that's how I do it myself.
Excellent. Any final thoughts from any of my co-panelists?
No, can I ask one question, sir, to all the panelists? Patient is all right prior to surgery, but after surgery, post-cataract dryness is a bit alarming. I want to know from you, is there any reason as to why it happens now? Earlier, we never used to have this kind of thing. Second thing is, do you start the patient on lubricant drops from the beginning from day one? You can answer, Mr. No.
So, I explain it to patients, right? I think a lot of it is we're irritating the meibomian glands. I think as we have more advanced technologies, we're just noticing it more. And, also, at least in the US, where like pollution's getting worse in certain areas. And so I think there's environmental factors where patients, and we have much higher rates of diabetes than we did in the past. And so there's a little bit of neuropathic issue there as well, I think, with the disruption to the normal system. But, to me, we're putting in an eyelid speculum. The meibomian glands don't like that. They get irritated and inflamed. And that is part of what kicks up the cycle of inflammation after. And patients, that resonates with patients on the, the dry front. But I have them all get a Bruder mask, and I put them on tears. And tears are great. I tell them it's a Band-Aid. It's not fixing anything. If you're going to do one thing, I'd rather be using, some high quality esterified omega-3s and a Bruder mask than than your tears, but they'll help get you through the day. And I do have them post-op. I don't necessarily start them on it. If they're dry before, I will do it. I will hold a cyclosporin for a month. I hold compresses for a month. I don't, no lid scrubs for a month, but I'll have them use artificial tears between if they have a penchant for dryness coming in.
I think we can have a whole webinar on just dry eyes. And
Absolutely.
obviously, treating it perioperatively at all levels is important. But obviously, J&J will not sponsor that webinar.
LipiFlow, I mean,
Very true.
they're in on it, yeah.
Yeah. So thank you so much, Dr. Ran.
Thank
It
you.
was wonderful having you. I mean, we're all very excited about this new addition to the repertoire of lenses that are available to us, and the initial experience has been pretty good. And you have reiterated our initial thoughts, and we look forward to using these lenses much more. And thank you, Johnson & Johnson, for putting together this webinar. It was very insightful. And I hope you have an excellent stay in India and a very happy journey onwards. Thank you so much.
Thank you all for having me. Best of luck with your launch of the Odyssey lens here and your early experiences. I think you're going to really enjoy it, and I look forward to hearing how it goes.
Thank you.
Thank you.
Thank you.
Thanks a lot. Thanks everyone. Thank you.
Thanks, sir. Thank you, sir. Thank you very much.
Thank you, sir. Goodbye.
Thank you.